So now let's have a look at the fascia of the neck. Okay, so what I've done here is I have removed the skin on the right side of our anatomical model here, and we can already see that deep to the skin there is some connective tissue, right? So this is not going to be the only type that we have here. This is the subcutaneous tissue of the neck. This layer here is actually pretty fatty, but there's actually also a deeper one. So in a nutshell, what we need to learn and understand is that these structures in the neck are going to be surrounded by a layer of fatty subcutaneous tissue, which we will call the superficial fascia, visible right now. I'm going to go ahead and hide that. And they're also surrounded by a layer of deep fascia. It's called deep cervical fascia. And the function of the deep cervical fascia is to compartmentalize the structures in the neck. So basically what we have is we have fascial planes that arise, and these fascial planes are clinically very important because they can determine the direction in which an infection in the neck can spread, for instance. So now let's briefly touch on the deep cervical fascia, all right? So the deep cervical fascia will consist of three different distinct layers. The first layer is going to be called the investing layer. Then you will have a layer of pretracheal, and then prevertebral fascia. And these here will support, for instance, the muscles, the vessels, the viscera in general, and the deep lymph nodes in your neck. Also, these fascial layers will help provide the slipperiness so that the muscles can kind of glide over each other, because even like very trivial actions like swallowing, due to the pull of the infrahyoid muscles, would be hard, and you would have muscles rubbing on each other, which leads to irritation, inflammation, and possibly a kind of bursitis otherwise. So this is why it's important that we have all the fascia here. In addition to that, clinically relevant would be that the fascial planes also form a natural cleavage plane, which is important for surgery, but also important for the dissection process. The first layer is called the investing layer of deep cervical fascia. This layer is the most superficial layer of the deep cervical fascia, and it'll surround the entire neck. It's deep to the skin and deep to the subcutaneous tissue. At several places, it'll actually split into two different layers, and they will then enclose or invest muscles, for instance, the sternocleidomastoid and the trapezius. The second layer of deep cervical fascia would be called the pretracheal layer. This is limited to only the anterior part of the neck, and it extends inferiorly from the hyoid bone that you can see up here, all the way down to the thorax, where it will then actually blend with the fibrous pericardium. If we had the heart here, it would be right about here. The pretracheal layer has a thin muscular part which will cover or enclose the infrahyoid muscles, and then also a visceral part that will cover the thyroid gland here, for instance. And in addition, also the trachea and the esophagus. Interestingly enough, this pretracheal fascia will actually be continuous with a type of fascia which is above and behind it, or posterior superiorly, which is called buccopharyngeal fascia, and laterally it'll blend with fascia which contributes to the carotid sheaths. The carotid sheaths will be containing three important structures: your internal jugular vein, the vagus nerve, and the common carotid artery. And it's important to be aware of the fact that the carotid sheath that surrounds these three named structures here, together with the pretracheal fascia, can communicate with the mediastinum all the way down here in the thorax, but also superiorly can communicate with the cranial cavity. And once again, this is important to remember because that means this is how they can spread infection or, for instance, extravasated blood. Last but not least, we have the prevertebral layer of the deep cervical fascia. So as the name implies, the prevertebral layer is going to be in front of or anterior to the vertebrae, and it kind of forms like something like a tubular sheath that engulfs the vertebral column and the muscles that are associated with it. For instance, muscles called the longus colli muscles and the longus capitis. This prevertebral layer is going to be fixed to the cranium superiorly, and inferiorly it'll kind of fuse with the anterior longitudinal ligament, which we should be able to see on the anterior aspect of the vertebral column right here. Laterally, this layer of fascia is going to extend as something that we call the axillary sheath, which will be the fascial sheath that surrounds the axillary vessels and the brachial plexus, the beginnings of which you can see over here. As we're already talking about spaces, we also need to talk about a space which is behind or posterior to the pharynx, so we'll call that the retropharyngeal space. This is important to know because actually this is the largest and most clinically important interfascial space in the neck because it is the major pathway for the spread of infections. It is like many spaces, just a potential space until we actually have something going on in there like an infection. In a non-pathological state, it's just going to be filled with some loose connective tissue that is going to be between the visceral part of the prevertebral layer of the deep cervical fascia and this buccopharyngeal fascia. Although there are way more details that we could elaborate on when it comes to the fascia and the fascial layers of the neck, as an introduction, this should actually suffice. Let's have a look at the subdivision of the neck into different cervical regions. Okay, so we can divide the neck, as you can see here. I've taken the liberty to draw with a pen on the surface. We can divide it into four main regions. Okay, so you have the SCM or sternocleidomastoid region. You have the posterior cervical region, which is back here. You have the lateral cervical region. And you have the anterior cervical region. The sternocleidomastoid muscle, which is going to be just deep to the skin here, actually, as you can imagine, will be defining the sternocleidomastoid region. This is important because everything anterior to it, or anterior to the anterior border of it, is going to be in the anterior region. Everything behind it, or posterior to the posterior border of the sternocleidomastoid, is going to be the lateral region, and of course posterior to the lateral region is going to be the posterior region. We need to remember also that the sternocleidomastoid has two heads, right? It's called sternocleidomastoid, which implies that it has an attachment to the clavicle and to the sternum. To illustrate this, see if I can get rid of this pen drawing and also if I can get rid of the skin for us. So here's the pen. I'm going to clear the 2D pen. Okay, the pen is gone now, and now I'm going to remove the skin. So now with the skin removed, I've actually superimposed in 3D pen the different regions again. And now you can see very nicely the sternocleidomastoid, and as I might have already stated, the name implies it has two attachments distally, which would be the clavicle down here, and the sternum, which would be over here. Actually, I have hidden the sternum, so the body of the sternum. However, the two heads are separated by a little space, as you can see right here. And this little space in between the clavicular and the sternal head of the sternocleidomastoid is actually called the lesser supraclavicular fossa. Now that we know that there are several regions in the neck, now we can dive a little bit deeper and familiarize ourselves with the triangles of the neck as well. So the triangles of the neck are not going to be synonymous with the regions, although location-wise they are close. They're not the same thing though, okay? So to make this most descriptive, we can see that the posterior triangle is going to be bounded anteriorly by the posterior border of the sternocleidomastoid right along here, and posteriorly by the superior border of the trapezius by these fibers that you can see right there, and inferiorly just by the middle 1/3 of the clavicle. So the roof or the superficial boundary of our posterior triangle, which really looks like a triangle here, would actually be by the deep layer, or actually the investing layer of the deep cervical fascia. And there's also a deep boundary, which would be the floor in that case, which are the muscles of the neck that then would be covered by prevertebral fascia. As you can see, you can look in here, that's where the deeper muscles of the neck would be. In contrast, you have the anterior triangle here, and the anterior triangle will be bounded by the midline of the neck, straight down here,
also by the mandible and by the anterior border of the sternocleidomastoid. So this makes a neat little triangle, which we can then actually also subdivide into 4 smaller triangles as we move forward. But let's have a look at the posterior triangle first here. So if we have a look at the posterior triangle, we can actually also appreciate that we can subdivide this again to 2 smaller triangles. One of these would be the occipital triangle, as it is part of or within the posterior triangle. You can imagine that, well, one of the boundaries here anteriorly is going to be the posterior border of the sternocleidomastoid, and the posterior boundary would be the anterior border of your trapezius. But then we have this little muscle here, which is actually the inferior belly of the omohyoid. Yeah, this will form the interior boundary. Yeah, so this would be your triangle here. So in that case, if this is called your occipital triangle, you would have another triangle down here, and that triangle is the omoclavicular triangle. Yeah, because omo from omohyoid and clavicular because of the clavicle. So for the omoclavicular triangle, you would have the inferior belly of the omohyoid as the superior border, the clavicle down here as the inferior border, and this little sliver of the posterior border of the sternocleidomastoid as the anterior border. But for simplicity, I'm just going to refer to the general contents of the posterior triangle when we talk about what we can find in here. To illustrate some of the contents of the posterior triangle, I've actually had to go ahead and add some more features. So now we have some vascular features in here as well, and some nerves. So we can see there's some part of the external jugular vein right here as it crosses the anterior border of the sternocleidomastoid. You can find this within the posterior triangle. You can also find some of the branches of the cervical plexus of nerves over here. The one goes transversely across the sternocleidomastoid would actually be the transverse cervical nerve, and you have other sensory nerves that are coming out of the so-called Erb's point, or the nerve point of the neck. You should also find the spinal accessory nerve, as that is the one that innervates the sternocleidomastoid, but also the trapezius. You will find your trunks of the brachial plexus down in here as they are moving into the brachium. You will find several cervical lymph nodes and also the so-called cervicodorsal trunk. And down here is the subclavian artery. Specifically, we will find the third part, so it has 3 parts, and we actually find the third part of the subclavian artery passing through the posterior triangle of the neck. So for completeness, why don't we have a look at some more of the nerves of the posterior triangle. I'm going to move this a little bit better into position, and we can see highlighted down here, follow the mouse cursor, here is the spinal accessory nerve. And an important tidbit, if you do not know that yet, is, well, I always kind of call the spinal accessory nerve a cheater because it's not really a cranial nerve, right? Cranial nerve number 11 originates from neurons in the spinal cord segment C1 to C5. It doesn't come from the brain, it comes from the spinal cord, okay? So the axons of these nerves or these neurons will actually leave the spinal cord, merge together, and ascend as a single nerve through the foramen magnum, which is the big hole in the skull, and then they will exit through the jugular foramen and pass downwards, and they will only supply, so the accessory nerve will only supply 2 muscles, one of which we see here, which is the sternocleidomastoid, and the other one is the trapezius. So accessory nerve, cranial nerve 11, actually comes from the first 5 segments of the spinal cord, and it only innervates 2 muscles. It is purely motor. It does not have any sensory function. Next in line, we actually have the cervical plexus. Okay, the cervical plexus is interesting. You can see some of it coming out from here. Yeah, as I said earlier, it's also called the nerve point of the neck, or Erb's point. And the cervical plexus, you can see some of the nerves here. Yeah, consists of the ventral rami of the cervical nerves 1 through 4. Yep, several of these branches you can usually see. In lab, they're a little bit harder to dissect out. They're often accidentally removed together with the skin, okay? But they appear posterior to the posterior border of the SCM, and if you are careful enough, you should be able to find some of these, okay? You'll find, for instance, this one here, which is the transverse cervical nerve. This actually supplies sensory innervation to the anterior triangle. See if I can highlight this one. This is your great auricular nerve, and actually auricle means ear in this context, so that'll actually supply skin of the ear and the parotid region. And then let me see if I can highlight this one as well. This here would be the lesser occipital nerve, which is for the skin to the ear and the scalp. And then we would also have supraclavicular nerves that are radiating inferiorly here. They will supply skin around the chest and shoulder region. As an interesting little side note, what you can do if you're performing anesthesia, you can actually do a so-called cervical plexus block. Yeah, that will be a regional anesthesia of the skin of the neck by blocking the cervical plexus. So the main site of injection would in that case be just superior to the midpoint of the posterior border of the SCM, so just about here where the mouse cursor is now. And administering an anesthetic over here would then knock out all of those branches of the cervical plexus. So let's finish off the posterior triangle just by saying 2 or 3 things about the so-called brachial plexus. The brachial plexus will be dealt with at a different time and in a different lecture series actually, because that is highly involved in the innervation of the upper limb, okay? But in brief, we can say this much, which is that the brachial plexus innervates all of your upper limb. Good. In addition, it has several parts. It has parts that are called roots and trunks, but it also has divisions a little bit further down, and it has cords and branches, okay? So there is a mnemonic, stands for Randy Travis, drinks cold beer. So roots and trunks, divisions, cords, and branches, okay? And it innervates all of the upper limb. So it has a lot of mixing and mingling that's going on between the fibers that originated from the spinal cord segments C5 all the way down to T1. So it's a large mixed plexus of nerves. One more thing about the posterior triangle in the context of the brachial plexus, we should note that the roots and trunks are above the clavicle, so they are supraclavicular, whereas the divisions are postclavicular, and the cords and terminal branches are just infraclavicular in position. So for anesthesia purposes, you can target the brachial plexus and you can inject an anesthetic kind of superior to the midpoint of the clavicle, and you could do a supraclavicular brachial plexus block. Well, as we've now talked about the brachial plexus, there's actually one quite important triangle we should not neglect, as this is one where we can find the roots and trunks of the brachial plexus emerging. That will be the interscalene triangle. Okay, the interscalene triangle is going to be bounded by the middle and anterior scalene muscles. So here's the middle scalene muscle, and here's the anterior scalene muscle, and down here by rib number 1. Okay, so the triangle will contain your brachial plexus and also the subclavian artery. I've hidden that right now, but not the subclavian vein. And one clinical correlation about the interscalene triangle is that it could become too narrow if there was something there like a cervical rib, although cervical ribs don't really occur more frequently than in, well, 0.5 to 1% of the population. If there was a cervical rib, that might actually compress the subclavian artery, which can lead to ischemia, so reduced blood flow to the upper limb. Also, as you can see, the brachial plexus is coming through the triangle here. You can imagine if there was an extra rib there, it could also compress the brachial plexus, which would then, of course, have its own detrimental effects on the innervation and functioning of the upper limb. Let's have a look at the subdivision of the neck into different surfaces. In this video, we're going to be dealing with the anterior triangle of the neck and some of the smaller triangles that we will find within the anterior triangle. Let's remember the borders or boundaries of the anterior triangle, which would be, for instance, the midline of the neck, which I've superimposed over here, the inferior border of the mandible, and the anterior border of the sternocleidomastoid muscle. So the sternocleidomastoid, or SCM, will separate the anterior triangle from the posterior triangle on the other side. So what I've done now, I've rather crudely superimposed the outline of the smaller triangles that we can subdivide the anterior triangle into. So one would be the submental triangle, which is actually fairly small. It's also the only unpaired triangle, so there's actually only one of these. And the submental triangle, as you can see here, this is actually outlined in black, is going to be bounded by the anterior bellies of the digastric muscles and the hyoid bone. Then you have the submandibular triangle, which is going to be over here, that is outlined in blue. Okay, so that will be bounded by the inferior border of the mandible and the anterior and posterior bellies of the digastric. So here's the inferior border of the mandible, here's the posterior belly of the digastric, and here's the anterior belly of the digastric. So this is your submandibular triangle. Then you have the carotid triangle. The carotid triangle here is bordered or outlined in pink, and you can see that the carotid triangle actually has a border of the posterior belly of the digastric as well, the anterior border of the sternocleidomastoid, and the superior belly of the omohyoid right here. And then last but not least, you have the muscular triangle, and the muscular triangle has a boundary here in the midline of the neck, the sternocleidomastoid muscle, and also the superior belly of the omohyoid. Okay, so now we've switched the view into an anterior view, and we also have a cadaveric image here that shows us the respective muscles. So the boundaries of the anterior triangle of the neck, we can see it nicely here. Everything except for the midline of the neck is highlighted. But so the midline of the neck together with the mandible and the sternocleidomastoid forms the boundaries of the anterior triangle. Okay, so body of the mandible, sternocleidomastoid, the midline just would be depicted as a straight line down here. Then you have your submental triangle. Remember, this is the only one that is not paired. It actually really does look a little bit like a triangle between the two digastrics and the hyoid bone. Then you have the submandibular triangle. As you can see here, your anterior and posterior belly of the digastric. These are actually innervated by different nerves. The anterior digastric by a branch of V3, the nerve to mylohyoid, innervates the anterior digastric, but the facial nerve innervates the posterior belly of the digastric. And then actually here's the mandible, the inferior border of the mandible. Here is your carotid triangle, and for the carotid triangle you can see it's the superior belly of the omohyoid, the anterior border of the sternocleidomastoid and the posterior digastric, and then the muscular triangle where you have the midline of the neck again, and the sternocleidomastoid and the superior belly of the omohyoid in this case. So what we're going to have to do is we're going to have to go through every single little triangle and see what the deal is with them and what kind of information can we learn from having a closer look at those. So let's start off with our submandibular triangle, all right? You can see here are the boundaries of our submandibular triangle one more time. You have the border of the mandible. You also have the posterior and the anterior digastrics. So what else do we find in here? So the contents of the submandibular triangle is going to be your submandibular gland, your facial artery, your facial vein, your hypoglossal nerve, which you can see poking out back there, and a couple of lymph nodes, which I have hidden from view just to keep the image as unmessy as possible. The roof of this triangle would actually be formed by the investing layer of deep cervical fascia, and a deep boundary, so a floor, will be formed by the mylohyoid and the hyoglossus muscles. So if we zoom in a little bit here, we can see this is your mylohyoid muscle, and this is your hyoglossus muscle. You should also be able to find this muscle here, which is called the stylohyoid, because it comes from the styloid process and then attaches to the hyoid bone. You can see that it actually crosses right over where there's this tendinous part, or the tendinous sling or intermediate tendon that connects the anterior and posterior digastrics to each other. And the stylohyoid is interesting because it actually splits and straddles the posterior digastric, kind of like someone riding a horse or something. It's straddling the posterior digastric, and then its fibrous tendon attaches to the hyoid bone down here. So next up is our submental triangle. This is the only unpaired triangle we actually have, and also this one will cross the midline of the neck. And there's not really very much in the triangle. There might be some submental lymph nodes, but other than that, we don't encounter a lot of really high yield material in here. So you can see here's the apex of the triangle, which is the mandibular symphysis. There's the left and the right digastrics. Remember what it's innervated by. The digastric by the nerve to the mylohyoid. Speaking of the mylohyoid, here's the mylohyoid because it forms the floor of this triangle. And the base is formed by the hyoid bone. Next up is the carotid triangle. Note the boundaries of the carotid triangle are your posterior belly of the digastric, the superior belly of the omohyoid, and the sternocleidomastoid. Within the carotid triangle, you're going to find a couple of interesting structures. Some of the major contents will be as follows. Your internal jugular vein, also called or abbreviated as IJV, you'll find the vagus nerve and the common carotid artery, and then if you follow the common carotid artery superiorly, of course also the internal and external carotid arteries and the branches of the external carotid artery. In addition, here you can also find the hypoglossal nerve way up here, and there's another little nerve which is actually called the ansa cervicalis. In this case it's the superior root of the ansa cervicalis, which hitches right on the hypoglossal nerve and then dives down. And you can also find the superior root of the ansa in the carotid triangle. See, if I fade the sternocleidomastoid muscle like this, we have a better view of all the structures that will be deep to it. Here are the different muscles, and here is the major contents. So the internal jugular vein extends all the way up and down here. Your vagus nerve, and your common carotid artery. This is before it actually splits. It splits a little bit higher up into the internal and external carotid arteries. And there's one more nerve here that we should actually already know if we've watched the previous videos, which would be your accessory nerve. Remember, I was mentioning that this is, although it counts as a cranial nerve, it's cranial nerve number 11. It's not really a cranial nerve because it actually originates from the higher, or the first 5 cervical spinal levels. However, if you find the accessory nerve, if you're doing a dissection, you might be able to find it where it crosses the deep surface of the sternocleidomastoid, and then it'll supply motor innervation to both the sternocleidomastoid and the trapezius muscles. So if we now look a little bit deeper into the carotid triangle, we can have a peek here, and here is the thyrohyoid ligament or thyrohyoid membrane. This is interesting because you can see there's a hole in it, and this hole is going to serve as a conduit for 2 structures. One of them is an artery and one of them is a nerve. Okay, so you can see the nerve that is entering through this hole in the thyrohyoid membrane is called the internal branch of the superior laryngeal nerve. This small artery that we can see here is called the superior laryngeal artery, And usually this artery will be a branch off of the superior thyroid artery, which in turn is a branch off of the external carotid artery. And here's the internal branch of the superior laryngeal nerve. Some actually also call it the internal laryngeal nerve. Please note that as this is the internal branch, that means there should also be an external branch, and sure enough there is. See, it actually goes all the way down here and it goes to the cricothyroid. Yeah, the cricothyroid is this little muscle that you can see right here, and also on the other side right here is the cricothyroid. Okay, in the middle you have this here, which is called the cricothyroid ligament. All right, and so the cricothyroid muscle is going to be innervated by the external branch of the superior laryngeal nerve, whereas the internal branch of the superior laryngeal nerve, let's see if we can find it again, the internal branch, you can see here, traverses the thyrohyoid ligament. It is both a somatic and a visceral sensory nerve. That means it'll be able to transmit sensation from the mucosa and the larynx, and also taste information from the upper larynx. This branch, so the internal branch, and the external branch you can see coming off here are both branches of the superior laryngeal nerve, which in turn is from the vagus nerve. Basically, it just arises as a branch from the vagus nerve, and then it descends on either side of the pharynx, and then it divides into your external and internal branches. Whereas, as I just said, the internal branch is primarily sensory, and the external branch is motor to the cricothyroid muscle. Now we're going to move on to the muscular triangle, and I have superimposed here also the outlines of the borders or boundaries of this triangle, and you can see one of them would be the midline of the neck medially, and then superolaterally you would actually have this little part here, this belly of the omohyoid. So that's going to be the superior belly of the omohyoid, because the inferior belly is down here. And we've removed a little bit of the sternocleidomastoid, but the sternocleidomastoid would actually make up the inferolateral border, whereas the superior belly, the omohyoid, makes up the superolateral border. If we think about the contents of the muscular triangle, well, inside there would be part of this large gland here, your thyroid gland. Of course, all of your infrahyoid or strap muscles are in here. And, well, speaking of the thyroid, on the back side of the thyroid, there are usually 4 small glands that are absolutely essential to life because they help regulate calcium metabolism, and without those you would actually have a tetanic muscle spasm in the end, and when that actually occurs to the diaphragm, or with the diaphragm as well, that would lead to death. So that would be your parathyroid glands. Might be jumping the gun on a clinical correlation here, but for people that have had a thyroidectomy, it's very important that the surgeon always keeps the parathyroid glands, because these are literally essential to life. I just went ahead and deleted that pen that I had. Okay, so again, midline of the neck, sternocleidomastoid, superior belly of omohyoid. So you can see here's the SCM, which is cut. Remember, it's called sternocleidomastoid. It actually comes from the mastoid process on the underside of the skull, right up here. And then it has 2 attachments, one to the sternum and one to the clavicle. Let's have a look at the strap muscles, and with the strap muscles, it's as usual in anatomy, the name is the game. So this one here going from the sternum to the hyoid would be the sternohyoid. We can hide that. Let's look in the deeper layer. Right deep to that is going to be the sternothyroid. So that runs from the sternum to the thyroid cartilage. If I remove that now, we can see down here is the little cricothyroid that sits directly on the surface of the cricoid cartilage and inserts onto the lower margins of the thyroid lamina. So when this little guy contracts, what it's going to do is it actually can laterally rotate your thyroid cartilage, and as it pulls it downwards as well, it will tighten the vocal cords, which means that it'll increase the pitch of your voice. Running right here from the thyroid to the hyoid is the thyrohyoid. Okay, so if we go through them again, thyrohyoid, omohyoid, cricothyroid, sternothyroid, and sternohyoid. So let's finish off this chapter now with a few closing remarks. First of all, you can see here I've highlighted for you in kind of a pinkish color. This is the superior and inferior roots of the ansa cervicalis. The ansa cervicalis is actually called the nerve loop of the neck. See up here where the mouse cursor is, this is where the superior root comes off of the hypoglossal nerve. It just hitches it right on there. Then it goes down and loops back around. This is the inferior root then. And so the interesting thing about this is you can see all these branches going off to the strap muscles. And so the ansa will supply 3 of the 4 strap muscles. That would be, in that case, the omohyoid, the sternohyoid, and the sternothyroid. The exception is the thyrohyoid, which will be innervated by a nerve called the nerve to the thyrohyoid. For a clinical correlation, as we are here in the midline of the neck, there are 2 approaches, or probably at least 2 approaches on how to create an emergency airway. The first one, as you can see where I've indicated the red line, would be a so-called cricothyrotomy. It's also called a cric, or thyrocricotomy, or cricothyroidotomy, or inferior laryngotomy, and so on and so forth. But what's important is actually that a incision is going to be made right here through the skin and the cricothyroid membrane, and that's has the purpose to establish a patent airway during like a life-threatening situation. For instance, like an airway obstruction through a foreign body. This procedure, however, is always a last resort procedure when, for instance, the orotracheal or nasotracheal intubation do not work, or if they're contraindicated. Also, the cricothyrotomy is actually easier and faster to perform than the tracheotomy, and it doesn't really require manipulation of the cervical spine, and it's associated with fewer complications. If we just move a little bit further down, here's your trachea. So the tracheotomy, as you can imagine, is similar. Tracheotomy or tracheostomy, because a stomata is actually an opening or an ostium. That is just the creation of an opening in the trachea somewhere down here. Again, this is an emergency operation, has to be performed rapidly in cases where there's sudden obstruction of the airway for the same reasons as the cricothyrotomy. The difference is you can have a more permanent, longer duration tracheostomy tube in the trachea, whereas the cricothyrotomy is actually only a very short term, so it's a temporary measure until you can establish a definite airway.